afternoon, everybody. My name is Chris Weimer. I'm the director of the Center on Poverty and Social Policy here at Columbia University. Welcome to the School of Social Work. At CPSP, we try to do sort of timely, rigorous, and policy relevant research to support smart policymaking. And New York State's been one of the areas where we've seen a lot of encouraging and exciting developments. New York State's always been a leader, for example, in having its own state child tax credit, and recently extended that credit to the youngest children in the state, age 0 to 4. And as Kate will probably tell you, there's an exciting initiative going on in New York State called CPRAC, which is the Child Poverty Reduction Advisory Council. Comes out of a New York State piece of legislation to create a council that'll make recommendations to cut child poverty in half over 10 years in the state. And Kate is a statutory member. Irv Garfinkel and I, who co-founded the Center on Poverty and Social Policy, have been lucky enough to be advisory members, especially on some of the tax work. So this is all to say that there's, in addition to some of the federal developments, which may not be as encouraging, there are real opportunities at the state and local levels to make a real dent in child poverty. And this event, I think, will be, in some ways, a kickoff to that work over the next year. And so without further ado, I'll just turn it over to Kate Breslin, who's the president and CEO of the Schuyler Center. Thanks.
Thank you so much, Chris. And thank you to Chris and the whole Center on Poverty and Social Policy team. Neither of us are really, sort of in the business of event planning. And it's just been a pleasure to work with their team to sort of figure this out together. So I'm delighted to be here today, and I'm so excited to be in person with all of you. So thank you for being here. It makes such a difference to be in person. I know so many of us just participate on Zoom, and we really designed this day intentionally to provide some opportunity for human connection. So that's why we, had a little time beforehand. We hope to have some time for you to chat at lunch. And we hope that the feel of the day will be very conversational and engaging. So we'll mostly be, we'll have panelists, we'll have people talking, but we also really want you to be, engaged and thinking and putting your perspective forward and asking questions. I'm nearly in tears, just like some of you I haven't seen in years, some of you I've never met in person. So in addition to thanking Columbia University, we'd like to acknowledge the Robin Hood Foundation and the Mother Cabrini Health Foundation for their support of today. Here's what we know. Nearly 1 in 5 children in New York State is experiencing poverty right now. These young ones, and many more, those in families above poverty, but still struggling mightily to keep the lights on, are homeless or doubled up. They're cold. They're not sure what they'll have for dinner tonight or if they'll have meals over the weekend. Children living in poverty are 17% more likely to have asthma, twice as likely to be hospitalized, and 2.5 times more likely to have toxic levels of lead in their blood. The brunt of these effects fall on families of color, who are more likely to have low income, less wealth, and live in neighborhoods with fewer resources. Many who experience poverty as children face significant challenges in the form of poor health, academic obstacles, and lower earnings for the rest of their lives. Here's what else we know. Children don't choose these conditions. They reflect generations of policy choices, disinvestment, and discrimination. The science of human development is screaming at us. Childhood adversity, when it is severe, persistent, and unmitigated, can lead to behavioral problems, learning difficulties, physical health issues, including chronic diseases like asthma and heart disease. In the early years of life, we have a radical opportunity to reduce lifelong disease by mitigating the effects of early adversity. A child's brain develops rapidly in the early years of life, and we know now what kinds of interventions can help or hinder. The effects of early experiences on brain and body partially explain significant disparities in health and learning by school entry, especially for children living in poverty. In recent years, our organization, Schuyler Center for Analysis and Advocacy, conceived of an initiative committing the state to cutting child poverty and addressing the unconscionable racial inequity in poverty. We organized with many of you in the room. We documented the conditions. We identified evidence-based solutions. We shared the data. We made the case. Dozens of legislators co-sponsored the bill that we conceptualized. Nearly all legislators voted in favor. Now I say all, meaning all, not just people with an R or a D on their names. Nearly all legislators voted in favor of a commitment to cut child poverty in half with attention to racial equity, and this governor signed it. We've got a long way to go to get the real win, eliminating child poverty, but our foot is in the door. Now we need to bang the door open. So the Child Poverty Reduction Act makes a public commitment to cutting child poverty in half in 10 years. To that end, later this month, the Child Poverty Reduction Advisory Council will release a set of recommendations informed by evidence, New York specific data, and dozens of experts, including those with lived experience. We need each and every one of you and the institutions that you work with to help make ending child poverty in New York a priority and a reality. You can learn how to do that with some of the links on the web or on these pieces of paper, and you can go to newyorkcan.org. The costs of inaction are stark. Ours may be the first generation of Americans for whom less than half our kids will earn more income than their parents. A report from the National Academies of Science, Engineering, and Medicine estimated that child poverty costs the nation between $800 billion and $1.1 trillion annually in terms of increased health expenditures, lost adult productivity, and increased costs of crime. We'll hear more about this specific topic right before lunch from the esteemed Erwin Garfinkel. Today, we are blessed to be joined by passionate, smart, experienced thinkers, both on the panels and sitting in the room, from across the state to explore the intersections of early childhood development, child health, and child poverty, the realities, the challenges, and the hope on the horizon. And we're just so delighted to be doing this with all of you. So thanks for being here, and we will transition to our first panel. May I ask, thank you. May I ask the panelists to join us in these seats here? Thanks. So as I said, we've structured today to be as conversational as possible. And I'm going to ask, rather than doing long introductions, I'll refer you to the QR code that has the whole program and people's long bios. But we're going to be asking each of the panelists, as we start with the questions, we'll be asking each of the panelists to say something about their work to sort of frame where they're coming from. So I'm going to just jump right in because I think that's where we need to go. So I'll start with you, Dr. Omolara Thomas. Can you tell us about your work and how you see the impacts of poverty show up in the lives of children and families who you care for?
Yes, so thank you. And thank you all for being here. It's really exciting to see people who care about child poverty and are extremely passionate about it. So my name is Dr. Omolara Thomas. I've been a pediatrician for now 20 years, which is making me feel very old. And I am the CEO and co-founder of Strong Children Wellness, which is an integrated healthcare model. And we actually do reverse integration, which some of you may not be familiar with, which is the idea of bringing primary care, mental health services, and social care coordination into the places closest to the community. So we work with foster care agencies, we work with social service agencies, and create a medical footprint so that they can get their mental health care, their social services, and their medical care in a one-stop shop kind of setting. And that work is really founded on, I would say, strong children. And that has been my passion. And I realized over the course of my career, when I started, I was really focused on creating strong children. Then I realized, oh, strong children need strong families. Then I realized, oh, strong families come from strong communities. And then, of course, as Kate knows, strong communities come from strong policies. And so in that, and money, exactly. And so in that, I would say that my work, the initial half of my career has been on global work, where I really was working outside the country and exposed to child poverty at a different level. And because of that, that has informed the creation of not just creating healthcare spaces that sit and wait for people to come to them, but realizing in the models that I were exposed to that there was a very community-centered model. One of the ones that was really important in terms of dealing with poverty was the consultorio model in Cuba, which some of you may be familiar with, where there's a doctor and a nurse almost in every block or two. And that model was the inspiration for this work. When it comes to health impacts from poverty, I would say I like to look at it in two ways. I think I have a patient who comes to mind where I worked with one of our partner organizations, Schuyler Center of New York, and I was doing home visits. And I did a home visit in Corona, Queens, with a patient who could not go to her physician. And so we said, okay, let's go into the house. She lived in a room in one of the row houses that was probably not bigger than this half of this area that we're sitting in, with her husband, her 3-year-old, and her new 6-month-old. Her 3-year-old was having significant asthma, and so and she had an asthma pump that she did not know how to use. And so when I think about it, I think about a few things in her situation. As an undocumented immigrant, I think about the fact that she felt very isolated, which is a huge impact that we have in terms of the stressors. I think that as a 3-year-old who, of course, are very rambunctious, the idea of living with other families and in this multiple story house and having to stay quiet and having only this room to be able to live in, and the developmental delays, both in speech and physical development. I think about the fact that she had a young child and did not have the ability to now leave and access childcare and be able to get into spaces where she could be economically mobile. And the lack of her husband, who basically I never saw multiple home visits because he was always out doing multiple jobs to try and keep the basic income that they could get. And so I like to say to myself that when we think about poverty and health, we have to really think about the fact that it is much more important, and I think most of us know that to figure out what is the housing issue than just giving this person an asthma pump, right? What is the legal issue that we need to support rather than just saying, okay, do these kind of things for improving development. So that's the thoughts that I have about that.
Thank you. Right on. We'll turn now to Halimah Washington. Please tell us a bit about your work at RISE, and then in what ways does poverty affect child and family well-being from your perspective?
Okay. Good morning, everyone. My name is Halimah Washington, and I'm glad to be here with you all today. I work with RISE. RISE is an organization or a magazine, an organization of parents who are impacted by the child welfare system or parents who've had their children removed by CPS. In my work, I see that parents impacted by poverty struggle a lot. One example of navigating or trying to navigate healthcare while in poverty, I'll give a personal example. Right now, I have a son I live in the Bronx, first of all, and that's one of the poorest congressional districts in the country. And in my neighborhood, I live up in Hunts Point, and it's not gentrified yet, but it's moving into gentrification, and there are healthcare centers all in the neighborhood. However, people in the neighborhood can access the healthcare centers, but oftentimes when they go, they have to deal with having insurance that doesn't really cover the services that they need. And they have to deal with, in my case, I have a son who injured his knee playing basketball, and navigating health, trying to get him an MRI and trying to get him to see an orthopedic specialist has been hell, because I live in the Bronx and I'm navigating healthcare while in poverty. It took almost a week to get an MRI. If we had better healthcare, he probably would have got the MRI the same day he went to the emergency room. However, we had to wait a week for him to get the MRI. He missed a week of school. So now I have to navigate getting him remote instruction. And that's been hell, because you have to work on the school's timeline. It's not like they're working on your timeline. And so he's missed school. Now we have an appointment with a specialist, an orthopedic specialist, but that's next week. And so he's going to miss 2 weeks of school, 2 weeks of instruction. And it's just like the stress of it all. And just thinking about the families that I work with, the stress of it all, and navigating this system myself, it's a lot. And I think that there needs to be a lot of changes. I can't list all of the changes, but given the story that I told, you all can guess what changes need to be made or should be made. And with that, I am complete.
Thank you. Yeah, I mean, I think both what I'm hearing, so just sort of the compounding stressors, the compounding and disparate nature of the stressors too, which starts, we all like to head towards solutions, but it starts to call out the fact that there's no one thing that can happen that makes everything better, that, poverty compounds. So I'd like to now introduce Dr. Alex Sheen. Can you tell us about your work and how the impacts of poverty show up in the oral health of children and families?
Yes. Good morning, everybody. My name is Dr. Sheen, Alex. I work as a clinical assistant professor at NYU's College of Dentistry. Very happy to be here. I was commenting earlier how a lot of the meetings and, events I go to are mostly just dentists who spend all of their time looking at teeth. So, that's usually all we talk about. But it's really exciting, I think, to be here and to have oral health represented on, in an area where, poverty really does affect the oral health of children. I'd mostly, work teaching students, teaching residents, didactically, teaching them how to drill teeth, put fillings in, but I think a little bit under that, really trying to help students, future dentists and future oral healthcare providers kind of begin to see kind of where a lot of the disease comes from. And I think oral health, when I was a child, and growing up, I didn't really think too much about it. But there's so many steps and layers that get to the point where you begin to have dental disease manifest. And as I've worked as an academic, as a dentist, I think one of the things, you see enough cavities and you see enough dental disease, you begin to kind of think about what are kind of the steps that lead to this. Traditionally, we're taught to, as a dentist, you get rid of the disease, you restore the tooth, and then the patient leaves. And as a pediatric dentist, a lot of times we, see kids come in, you take care of their fillings, and then they're back 2 years later with more cavities. And you begin to wonder what are kind of the ways in which we can maybe prevent them from coming back, and what are kind of the things that are leading to that. So, I like to joke how whenever I'm amongst, friends who or people I meet who, realize I'm a dentist, they always have, a dental story. They tend to usually begin to talk about their teeth or ask me questions about, their teeth or their child's teeth. Usually they're not great. I don't think I've ever had anyone say they'd had a great dental experience. And it reminds me that I think I take for granted sometimes. When I look at teeth, I see things and it almost has become normal, which whenever I'm around, my friends, I speak about things as if they're normal, but, they may never have seen it. So, when I think about poverty and I think about its impact on, children's oral health, there are plenty of statistics, and I think it's not unbelievable that kids who come from families in poverty tend to have more dental cavities. We call it dental caries. Sometimes you'll see it seen, but just cavities. They tend to, utilize their dental benefits less. They tend to have more untreated health needs. But what I thought would be really impactful is I have some pictures, which I think will just give a little bit more kind of perspective, immediate perspective on kind of what the impact of, I think, poverty and a lot of the social determinants that kind of are within that web can have on children's health. So I have multiple ones if you'd like to take a look. I don't know if we can, just pass them around. And for everyone who's online, I apologize. I don't think this is very evident. You could zoom. But this comes from the oral health report that was released by the National Institute of Dental Craniofacial Research, the institute there. This was a very big report that went over a lot of kind of the state of oral health in America. But this was just a picture that I saw that I think really demonstrates kind of the progression of what we call early childhood caries. So early childhood caries is just a kind of fancy way of saying the disease that kind of causes cavities. And, when I talk with my friends, it's always like there's holes and there's, these, maybe they're stained, maybe they're not, but it really is a disease, and it's a chronic disease that, is impacted by a lot of determinants and a lot of things that happen at home. And you can kind of see within this image the progression of that. And so, we see I had a patient, not too long ago who presented with, the caries that is all the way on the bottom left, I guess bottom right from looking at it. And unfortunately, I think it's far too common that we see children who have that level of disease. And this child is probably not more than 3. And so it's one of those things I think that, are very evident when you see, there are certain diseases that are happening within the body, but this is a very, I think, front-facing disease that we see a lot. And, and there's, I think, a level of treatment that we can certainly treat this. But the fact that we got here, I think, speaks to a lot of underlying systemic issues that, my colleagues have already, I think, brought up a lot of those issues. But I do think that, for oral health to be kind of, a part of the discussion, and that there are effects. And then, downstream, we have missed school hours, we have dental pain, we have emergency dental, emergency department visits where they just keep getting antibiotics over and over without any treatment. So I think that, we talk a lot about increasing access to oral health care, which certainly I think is great, but also beginning to understand and address the underlying determinants, and poverty certainly, I would say, is one of them. And, I think from this image, we can see just kind of that progression without kind of breaking that cycle of poverty. This just is kind of a continuous cycle that goes over and over. So.
Thank you. Thank you so much. We have such a great group here. So, Dr. Omolara, your work focuses on health and equity. And, from each of you, we've heard about sort of the inequities associated with poverty among our children. So can you talk about, sort of from the perspective of health access, some equity perspectives that are connected to poverty and racial equity?
Yeah. So once again, as I told you, most of my initial career was in global health, and a model that stuck with me was a lot of times in those areas, we do maternal child health. So we're seeing mothers and children. And one of the big models that I really has been helpful in thinking about access has been the maternal mortality model, where there are 3 levels of the barriers that we see. The first one being the access to either the knowledge about what is it that are the signs, the symptoms of, when I know that I'm having an issue with my child or with the mother. And so it's a health literacy access that a lot of times in poverty, people have competing priorities. And this is not the thing that we are focusing on getting our light bill paid or getting food into the house, and not really understanding, is this cough something that I need to go in for now? And potentially, if I do, I'm going to have to take off from work. So what can I do in the meantime? The second level is the actual tangible geographic time, distance, cost, access. That was the huge reason why we created SCW and decided to put models in places that are health deserts, like in the Bronx. And in Queens, we focus there. And in these spaces, that allows for a lot of our families who were taking 2 buses to come see, us when I was working in an academic center, and all of these issues, and realizing, hey, I don't have the cost. I don't have the money to be able to incur that cost. And that, of course, leads to preventable hospitalizations and ER visits for things such as ear infections and things that just get worse because of that. But the third layer of access has been the one that I think has been most important and sorely lacking, which is, even if I get to the space that I need to get to, for many of our families who are in poverty, which is disproportionately Black and Latino, there is the quality of care, the medical racism that they deal with, the lack of being believed, the lack of being taken seriously. And that has been the hardest place for us to be able to crack. And I think a few of the things, the models that are really important about equity and access, have been trying to ensure that there are more people with lived experience, more people who can understand and have the ability to be able to be in these spaces and have seen the communities and have seen what poverty is and have not dehumanized people who experience poverty, have more of those people in the spaces, including using community health workers and using, I would say a more diverse cadre of health workers, just rather than just a clinician. And so what that's looked like for us has been making sure, I think equity is a good place to start, but I think some of us have focused on equity as the outcome. And I actually think that there are structures that are keeping people from having the same amount and the same resources. Equity says, let's give some people more resources, right? But the structures will stay the same. I think we need to move to a justice model, but that's still not it, which is breaking down these silos, right? Saying, if I see an asthma patient, I'm going to talk to my housing people. I'm going to talk also to my climate change justice people, and we're going to get together and do some upstream work around, why is this happening? It's not just, let me give the resource. But then I think even with justice, even though our goal is to break down those silos, the thing that is really important is not just giving and not using a savior model, but really collective liberation. And I think that's where we need to be, which is the idea that a parent is able to have a space where they can say to themselves, I am not constricted by these services around me. I have the ability and the resources. I have become economically mobile, and I can make decisions that aren't short-term, that aren't urgent, because now I've gotten the resources that I need. And I think that we are stunting ourselves by just saying, hey, our goal is health equity instead of liberation. And that's how we need to start thinking about the policy work and what we do. And will this liberate our families, instead of just, can we just help our families to make it through the day?
Yeah. 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 We've got a long way to go, right? Well, and I think that's a challenge always, because it can be overwhelming, right?
Yeah.
That, that's a lot. I
It's a lot.
agree. And that's a lot.
Yeah.
Yeah. So, you know, that's part of the reason that for me, it's so important to be in community too, because we'll get there. And we got to do it together. Dr. Alex, how does the poverty experience by families translate to the inequities that we see in oral health outcomes and access to care for both children and adults? And I want to just call out, often in oral health, you know, the dominant mindset is, well, those people have bad behaviors, you know, and so like, how does the experience of poverty end up, you know, translating into oral health?
Yeah, so, I'll tell a quick little story. And generally, with students, we teach them to not only, when doing exams, to provide what we call, nutritional counseling, oral health instruction, talking to parents about things like what are kind of the foods you want to avoid if you don't want, cavities with your kids, what are some of the brushing habits and techniques, how much time you need to brush. And one student told me that he had gone over, all of this with the patient, and the mom just kind of said, "Well, I don't really have time for that because we're kind of in between housing, shelters, and it's kind of tough to really rush for 2 minutes or find any time." And, I think with a lot of kind of the instruction we give, and I kind of alluded to this before, is, the cycle of cavities isn't something that generally you can just fix and expect not to come back, because it can come back if, the underlying issues aren't solved. And I've had, like I said, plenty of friends who've asked me about advice, and they generally, kind of implement it immediately. But as we kind of talked about before, there are so many barriers systematically that prevent a lot of parents and families from being able to actually really kind of take care of their child's oral health. And I think one of the things about dental disease is that we tend to see it affects families, and so it's not really just the children, but it also is the adults. And I would be remiss to say, with children, they all have insurance through Medicaid, which is fantastic. But adults tend to not, depending on which state you're in. Some have a little bit better benefits than others. But certainly, the adults' experience, as I've alluded to before, plays a huge role in how they translate it to their children. And if, adults from childhood growing up don't really have good experiences or never really had the ability to take care of their oral health, it tends to kind of, again, exacerbate down to the next generation and down to the next generation. And so, I think there was a study that was done that showed, I think, that parents and adults who had dental benefits in those states, the child oral health outcomes were much better. And so, I think when I think about, poverty and see with families, it really is kind of a collective family unit. As we said before, children, when you're 3, you can't really brush your own teeth. And you can't really choose the foods you eat. And a lot of these families, we tell them to eat better foods, or we tell them to, less juice, less soda. But sometimes, depending on where you live, as I'm sure that's all you have available to you. You can't really go and get nutritious foods. Sometimes you don't have, the material benefit to afford some of those foods. And so really, I think, in terms of thinking about how we approach oral health care, at least, there is the point of, fixing the cavities. There's a certain point at which, if you look at that paper, you need to get children out of pain, infection-free, things like that. But also starting to think about the ways in which we can improve some of the determinants that really lead to that stage. And without that, usually it just keeps persisting up until adulthood. And, these are just children's images, but again, there are plenty of adults who, lose teeth. That affects their ability to get jobs, their confidence and ability to, be productive and provide for their families. And so these things tend to carry until we break that cycle. And I would also, want to point out, I know sometimes living in New York City, at least where I do, we forget that New York's a very big state. And, a lot of rural areas tend to have very high need and a lot of dental disease. And I think there was a report that was released by the Schuyler Center that showed that a lot of these high need areas are actually out in the rural areas where, as we talked about, transportation is a massive issue. And if you, have to travel 50 minutes or an hour and a half or take 2 trains to get to the dentist, and the dentist says, well, we need to, take care of these cavities, but it's going to take like 3 or 4 visits, taking off work, having to take kids out of school in order to do that really isn't a viable option for a lot of families. And so, you know, with respect to kind of the effects we see and the disparities we see, you know, those disparities are really amplified not only in the actual manifestation of the disease, but also the ability of families to, you know, maintain, you know, their children's oral health.
Thank you. That's a lot. Yeah. So Halimah, in your experience, and I appreciate you sharing your personal experience just now, previously, how do you think sort of the people who are working directly with in community, like the healthcare providers or social welfare providers, can better honor the experience of people who are experiencing poverty daily?
Thank you for the question. I think that, so some of the work that I do outside of being a project manager at RISE is I'm also a doula and a community health worker. And so what I think healthcare professionals can do is meet people where they're at and understand that, you know, having resources available for the folks that they're working with would be helpful. Knowing what resources are available would be helpful as well. And oftentimes the resources that are available sometimes are just, they suck. For lack of a better term.
Yeah.
I mean, you know, thinking about just a family the other day that I worked with, they went to the pantry or to the neighborhood pantry, and they received some produce and some meat and some other things. And a lot of the produce was spoiled. And these are people that live in a food desert to begin with. And it's like it's not only just having the resources available, knowing which resources are good and asking the families that you meet with before, if they, you know, having a conversation with them and finding out where they're getting their needs met is helpful. And then sharing that information with other people. And then, you know, I don't even know, to be honest, because it's so much
Yeah.
that needs to be done. It's overwhelming to even think about. And some of the other issues we see working at RISE is parents will be punished for not bringing their children to doctors or not following the prescriptions or the doctor's orders.
Can you talk a little, because I think we have a mix of people kind of in the health space and in child welfare space or early childhood space. And when you say punished, I want to make sure we're unpacking what you know,
Okay,
what you
so-
mean when you say
So
that.
when I say punish, families can be charged with neglect, medical neglect, and have their children removed for not following these orders and, you know, not taking their children to the doctor, or not their children not going to school for a toothache, you know, missing too many days of school. But going deeper into that issue, oftentimes there are no dentists available in certain neighborhoods. There are waiting lists that are months long at a time for some families to get in to see the dentist, and that's oftentimes upsetting and discouraging. Thinking about, you know, families that are trying to navigate even the school system and bringing their children to school or sending their children to school and not having adequate clothes for their children, or their children not having a coat in the wintertime, and, you know, being punished for that, or what we say is for reasons of poverty being framed as neglect. And these are the reasons why parents are being punished in a lot of communities that we see at RISE.
Yeah, thank you for that. And I'll just call out your point around sort of the lack of access to oral health care. And, that's part of we really think that's important. That's one of the reasons that we're diving into that pretty deeply at Schuyler. So, and then also just calling out, thank you for raising the issue of, in our child welfare systems, we essentially criminalize neglect. We criminalize poverty. Conditions of neglect are, include certain things that are really just the result of poverty. So thank you for sort of lifting that up. That's one of the reasons we wanted sort of this kind of multi-issue, multi-sector conversation. Bring it.
Because I think this is really important. And I think just going back to thinking about healthcare workers, social service, I think there's a training, an unlearning that we are trained in that looks at, that is so superficial and does not, and I think our medical system also heightens the fact of efficiency versus effectiveness, right? So the idea of, right, and risk aversion. So the idea of getting through the patient, not engaging, not looking broader than, okay, you have an earache and you didn't do this, why didn't you take the medication? She's probably writing in the chart, non-compliant, instead of understanding that I had to go to work, I had this issue, and trying to figure out how do we circumvent that issue, the larger upstream issue. We are not taught that. Only now in this past decade are people even learning about social determinants of health. Only in this past decade are people unlearning things about, Black people have more pain tolerance or have thicker skin than white people. These are the things that we were taught. And it is really concerning because the people, when we're taught that, that's what we pass down. Medicine and all of these things are apprenticeships, right? And so it's just really important for us to unlearn and to also understand the fact that everyone can be, an advocate for themselves, right? And not saying, here, this is what you can do, but empowering patients with the idea that, look, if this is how you're being treated, this is not acceptable, right? And these are the potential resources or places that you can go, like you said, vetting places and saying, these are the specific places where you'll get an advocate. And the last thing I'll say about this is the idea of not having these spaces for healthcare that are so, traditional around, this is who needs to, a nurse, a medical assistant, and a clinician. One of the things that's been really insightful for us has been to have community health workers, to have care managers, to have behavioral health clinicians, to have interns who live in the community and come and work with us to help engage. And that has unleashed a whole, I would say, penetration in terms of being able to communicate at a different level, as well as creating an ecosystem of community partners. So it's not doing it by ourselves, not healthcare, not saying, well, we deal with health and everyone needs to come to us to figure that out.
What are the barriers to creating those sort of more person-centered or
the biggest barrier is money, right?
What?
Everyone knows that. So we'll move past that one.
Talk about that.
But
a little bit.
exactly.
Like what you mean by that.
We'll talk about that. I mean, the biggest thing, right? And even I was at a different talk where we're talking about Medicaid. If there's anything that is the most closest to my heart and the thing that makes me so angry, it's Medicaid. Particularly not only in terms of the reimbursement of Medicaid, which is so low that now only very few care centers actually and practitioners will take it, right? And so this is what leads to these long waiting lists and burden, because the clinicians, of course, they stay in business, and to be able to offer, they have to be able to get some kind of payment in order to continue to do that. And so the level of reimbursement, but also the things that aren't reimbursed, right?
Right.
So the things that we found that have been so instrumental for our families has not been, I mean, yes, I think clinicians do good work. Yes, I listen to the heart, do all of those things, but it's the care manager next to me who is doing, like, calling up the patient, doing a home visit. These things are getting reimbursed, but then there's the small things like setting up transportation, setting up a subspecialty appointment, so you don't have to, right? And you can go and do these other things that you need to for your child. And those things are only now starting to get reimbursed. And this is only on a state level. So we're just seeing, we're starting this process, and it's long overdue. And that's the huge money aspect of this whole issue. So, I mean, I think I answered your question, I hope, because I can ramble
I
when
feel
need
like
to.
Dr. O is basically meeting people where they're at.
Yeah,
Yeah.
yeah, yeah.
And helping them get to where we would all like them to go, health.
But not just saying, okay, here is your $400 of SNAP benefits that is so for the month for your family of 3, right? Not just saying, here, we got you that, so that's good enough, right?
Yeah.
Saying, what is it really that you want to do? Like, is it like more education? What is the thing and figuring out who are the people? Because not no one organization is going to have it, but who are the people, and really engaging with the family, knowing that this is a bridge to just be able to, like, really think about what you need to move out of poverty, and having the respect
Yes.
with your families to really look at them like, is this the situation I would want my family member to be in, and what would I do?
Right.
Yeah. Halimah, is there a policy or program or what that you alluded to it a little, you sort of said the resources or the options suck. Is that?
They do.
But like, do you have thoughts about what, and again, recognizing that we're talking about a lot of different things, and there are a lot of layers of things, but is there something that you think, could be done differently that would make a difference?
Yeah, so actually, I'm working on with a group of other organizations. We're working on a child and well-being fund here in New York State that's setting up a fund for organizations that are actually doing the grassroots work in communities to help them get the money that they need, like funnel it directly to them instead of having to go through all of these hoops of fire to get the resources to help people the way that they have been helping people. But what has been happening is bigger organizations with better grant writers and folks like that are getting the money, while grassroots organizations are doing a lot of the work, but not getting a lot of the resources. So working on this child and family well-being fund, write that down, folks. It's coming, but that is one of the policies that should be
And we're, full disclosure, we're working with Rise and others on that.
But it's in the
idea.
works, guys.
Yeah.
Yeah.
And one of the ideas really being sort of what we talked about earlier, like that we shouldn't be criminalizing poverty, and that and because one of the components of the thinking behind that fund is that funds wouldn't go to entities that are also mandated reporters.
Right. Yes.
Like sort of trying to break that sort of, that habit of, that we have everybody in the world has to be a mandated reporter and
the over-policing of families that are in poverty. Yeah.
Yeah.
End it.
Well, I'm gonna, I was just gonna say, and then we're gonna ask you all to sort of, put forward your ideas, bring your questions, that sort of thing.
Yeah, and I think also as kind of an educator, one of the things that I've noticed, and when I was a student too, especially as a dental student, you're very kind of siloed, and I think it very much kind of manifests itself in the way that care is, in the delivery care system that we have. And when I was a student, I remember the integration of oral health and systemic health was already kind of a buzzword and buzzing, and we used to talk about it a lot. And, all this time later, I think steps have been made, but, I don't really think it's enough. And I think it's evident in the way that, we have long wait lists, there's really no communication. And, I used to have friends in the medical school who never really thought about oral health either, ironically. They'd be scared to look in the mouth. They didn't really, be like, oh, I don't want to get bitten. So, you kind of just, hands off and go see the dentist. And it's not to say that, that a physician or someone shouldn't be able to have to do all the dental work, but I think just the way that we educate at that level, if we begin to really think or encourage students and residents to really begin thinking not just in their kind of silos, and this goes to dental students as well, but really thinking about patients, whether they're children or adults for that matter, in kind of a holistic way. I do believe that will begin, if the culture around that changes, it should manifest in the way we think about when we have, these, residents become physicians and dentists working in the system. And I find that at least when I talk with, friends who are, medical colleagues, or I'm, talking with people who are outside of the dental field, it really sometimes is kind of a hands-off. And I think that, and when I speak with dentists too, it's just kind of, well, I only deal with teeth, so I'm not really going to think about anything else. And so, it's not to say that I think that we should all just be doing each other's jobs, so to speak, but I do think that the way in which we see children, if, we see a child who might have something that's not dental related, that we'd have the referral system set up, or the ability to feel comfortable just calling their physician, instead of saying, oh, just go schedule it with your physician, and, vice versa. And so as an educator, I do, try to, but I really, secretly hope and encourage, when we train our physicians and we train our future dentists and all, really any healthcare provider in between, that we begin to kind of think holistically about patients. And I do think that should hopefully begin to lead into things like, well, are we looking after their housing? Are we looking after, their ability to get food, and things like that?
Thank you. That's an issue that I know comes up a lot too. Just sort of like, a lot of kids, for example, won't see a dentist till their teeth emerge. But so we really need our pediatricians and primary care providers to be thinking about babies' teeth or babies, teeth to be. And yeah, we hear that a lot, that there could be, this is, almost, it affects the patient, but outside the patient, that our clinical professionals need to be communicating better with each other. Primary care clinicians and dental providers, OBs and pediatricians, at all levels. Yeah. Well, I'd like to invite folks to sort of, weigh in on the conversation, ask questions. Marjorie.
Good morning, and thank you so much for all of your insightful words. This has been amazing, so thank you. When you mentioned the low Medicaid reimbursement rate, it made me wonder about if it would be possible, just so wondering if for practitioners, if we could say that they must serve X percentage of their patient population needs to be folks who are on Medicaid. Could that be a solution for some of the access issues that we're facing? That if we had policies that made it a requirement for every practitioner that they serve, that 20% of your patient population must be on Medicaid, could that be a solution? Just curious.
It's interesting because it's kind of like what we see in housing, right? Where the affordable to get people to have more housing options by incentivizing developers. However, that comes with a nice chunk of change as well to help support their the ability to do that. I think the issue for a lot of private practitioners has been the fact that, and I say this as someone who is in this and learning this now. I did not know this when I was under my ivory tower of the academic center. I just see patients, I get my salary. I did not know what is behind how to make sure that this thing runs, right? And we take care of 85% Medicaid, but we have to be so innovative. We have to say, let's take advantage of this program, which can provide more reimbursement in this program. And unfortunately, the place where we lose money is in the primary care, right? But larger institutions that, let's say NYU or larger, they have their surgeons, right? Or they have other things that can come in to subsidize it. But in the private level, it's really hard. So what we see is that the government does give money to like FQHCs, right? To be able to say, these are the places where you can go. But if you think about how many people are in need and the fact that the poverty rate is, the unemployment rate is rising, which of course is a proxy now to move into poverty, we see that those places are getting overrun. And now the issue is, how do we make this better? And these are going to require federal, or which we know is a crapshoot right now, or our state, right? Especially in states that we feel have the governance that needs to be pushed, but can be pushed to say, hey, what can we provide to these providers to make sure there's access? I think that that's a great idea, but I think there needs to be funding behind it to really support that. I don't know. She's the policy one, so I don't know. She might know better.
If I could add to that, so I mean, there's so many things I could say. So I'm Dr. Maya Castillo. I'm a pediatrician by training and pediatric medical director at Health First. And, one of the reasons I went into what I'm doing is because as a pediatrician, Omolara and I've talked about this a lot, I felt like I couldn't provide for my patients what they really needed. And it was because of money and because you just don't have the structure. So I've been with Health First now almost 5 years, which feels crazy. And I've really learned a lot about how far back in the way the system is set up you have to go to fix it. Because to say to provider, you have to see 20%, our providers are already struggling, right? And nobody taught doctors to be business people, right? Or dentists, or right? So, systemically, and then you go back to the health plan and everyone's like, well, the health plans are rolling in dollars. Yes, commercial health plans that have huge commercial, a plan like Health First, which is really Medicaid, Medicare, like we are struggling too. And so then you go back even further to the state, and then you go back to CMS. And it really is that at the base of it, our whole structure is built on this capitalist society that looks to, where the money is and what are the goals of the politicians. And really, it's not about taking care of everybody or taking care of poor people or bringing everybody up. Right. And until we can fix that, I think Omolara said something that really struck me. Until you get back to that, right, we're just putting patches and patches and patches. And so, yes, the Medicaid rate needs to come up, but there needs to be a standard health care just available to everybody. And it needs to be easy. I mean, I know you said you struggled with your son, but another reason I went into this is I had a very personally traumatic healthcare incident where I was paralyzed and I couldn't figure out how to get health care. And I sat there thinking, if I'm a doctor and I can't figure this out, how does anybody figure this out? Right? Like it has to be easy. It has to be available. It has to be right there that you can just walk in like what Omolara has created and say, everything I need is here. And we've got to create that. We can't just say, doctors, you have to see more Medicaid, right? We've got to create that base. I'm done.
They'll be leaving in droves.
Thank you. That was.
Hello.
Hello.
Hi. So I have a question. I don't want to say your name incorrectly.
What's your name?
Tarsha Black.
Thank you, Tarsha.
Hi. What is your name, Doctor?
Omolara,
Omolara. You said you work with CCNY?
Child Center of New York?
Yes, that's actually one of our programs. I work for the Department of Youth and Community Development, DYCD. So they actually fund thousands of community-based organizations in all 5 boroughs. Question, do you also work in other boroughs, or can you connect to other CBOs to provide this type of service?
So we have been, I'm like- so we have been, I would say, slow and steady trying to make sure that the model works, right? And so we have been in Queens, but one of the things that we have done, which has been exciting, is working with foster care agencies and residential treatment facilities. Our mission is to find the kids who like really, really need wraparound support, and then to figure out, okay, what level of integration can we do? With Child Center, we actually got funding to like create a medical footprint inside of their centers. With organization like JCCA, which we've had a long-standing relationship with, we have some of our providers go to their site and now provide continuous primary care. So it's not just someone they're picking, but now someone who every week, they are following them, in between they're following them. And even at residential treatment facilities, being able to have a standing physician from our space who can come back to us and who has, I think one of the things that's really important is not every, and this is just like any specialty, not every physician is really interested in doing like social needs screening and learning about homelessness, and they're like, I don't want to do all of that, and really trying to figure out who are physicians who are really interested in this work, and making sure that then we can put them in the places that they are. So or I should say the short answer to that is we are open to really learning what kind of partnerships, because that's what we do. So we usually have different community partners, and they can be as little as warm handoff relationships where now you know us, we know you, and we also provide medical transportation. So we have patients who come from Westchester, who come from here because they see a practice that has 3 Black women leading it, and it has like basically women of color all through it. And they're like, yeah, I'm gonna go to that one. And so we arrange transport to make sure that cost and distance isn't an issue, but our goal is to slow and steady get into the boroughs if we have a good community partner.
How do you fund those services like transport?
Yeah,
and
so
other-
transportation, we use our, we are the ones who schedule, like Medicaid has those, opportunities, but a lot of times it's hard I had to deal with this as a family member who trying to schedule like transport is like a whole new job, right? And so we have navigators who every family has access to, and they're the ones who, like, if there's something going on where they want tutoring for their kid, like they will look up the support. So they, whenever appointment scheduled, they ask do you need transport, and they'll schedule the Medicaid transport for the day of the visit so that they can come in and out.
I think what I love about that, so for the programs like CCNY and other programs, especially in Queens right there, they actually offer the after-school services, the other services. So I think connecting the families to them sounds like a win-win. The other thing I wanted to ask you, have you ever heard of the Family Development Credential Program?
No.
So it's called FDC, right? We call it FDC for short. And it actually speaks to what you have been speaking to about a holistic approach, a strength-based approach to work with rather your city organization, a community board, a CBO, or just people, just how to work with families, really. It takes a different approach when speaking about poverty. I mean, I grew up in public housing. Speaking about that, it helps you look at the person, speak to the person, ask them what they like to do in terms of next steps, and then helping them get those particular resources. And so there's actually a program that's offered through my agency. Spring 2025 applications are currently out now. You can go to our website and you can get the link to do that. Or if you give me your email, I can send you the email. I can do that too. But it's a great program. It's actually going back to school. It's 14 weeks, but we just graduated 130 people. literally yesterday. So we just
Nice.
graduated 130 people
And
in
what
this
kind of
program.
places do they end up finding work? Is it work?
So they come from different agencies,
Okay,
different, so
they're
different
usually
state
sponsored
agencies.
by a-
Yeah,
they're
so
already
we
working.
sponsor
Got
them.
it.
We have a scholarship.
Yep.
They apply for the scholarship. So whether
Great.
you're from ACS or DOE or anything like that, and then you go and you take doctors, lawyers, and now you can work with your families better on a strength-based approach.
Like
More of a holistic.
continuing education.
Good track,
Yeah,
correct.
thank you.
Beautiful.
We actually partner with CUNY. So yeah.
Wow. Thank you for that.
Right on. Right on. Other like either questions or comments?
I'd like to have a further comment on the policing of families in poverty, if you can talk about that. In the sense of most people think that most children in foster care are there because of some ill deed, but in fact, much of it is just economic.
Exactly. Just what you said. Most oftentimes people think that children that live or are in foster care are there because of some heinous abuse reason or whatnot. And the truth of the matter is most kids have been removed for just that, reasons of poverty that has been framed as neglect. And so, for example, a kid going to school with a t-shirt on in this weather, or just a sweater. The teacher calls and report on the family because the child doesn't have adequate clothing. And so now an investigation has to start, which can last from anywhere from 30 to 90 days in some instances, depending on what the family's history has been with ACS. And now, oftentimes, ACS keeps a history of families that are in poverty for generations. And so if a mother was investigated, a grandmother, auntie, and that child who had the t-shirt on is removed, now they can't go into kinship care or with a family member because of the ways in which ACS or Child Protective Services or Child Welfare investigates families and everyone around the family. And so because of those investigations, now the child can't go to that home, and now they're placed in the system for the system to do the same exact thing. Now the parent, the child didn't have a coat because the parent didn't have money for laundry, let's say. Now, instead of ACS coming in and offering support to this family, or the teacher or the school offering support, it is a report that is done. And now the child is removed from the home and put into the foster care system. And the foster care system is resourced with all of this money to support this child when they could have simply given that money to the family, and the mom could have washed the coat and appropriate clothing for that child to go to school and not have a report. That's the way in which child welfare. Yeah, I forgot what I was saying.
No,
Yeah,
Just-
that's poverty intersect, right?
Yes, yeah. This is the ways in which poverty has been framed as neglect. And so now the family has a neglect case and the child is removed. That simply.
Yeah.
There is a organization that we partnered with because of this, and we were seeing some of our patients who were being just called, having reports at the Center for Family Legal Representation. And so it just shows like there's organizations now that are created specifically to
Right.
be the legal representation because of how rampant this is. And honestly, a lot of my Black and Latino families, I've you know, I feel like sometimes when I'm saying, okay, you're gonna go to this physician or you're gonna go to this space or whatever, I feel like I'm having the same talk I had with my child about police encounters. That healthcare and social care encounters are the same kind of, okay, we got to get ready. And that is really disheartening, and
Very.
it reinforces kind of the same like policing structure and the same way that bodies are being, you know, attacked. And
And the compounding stress of it. right?
Yes.
Like just, yeah.
to abolish mandates.
That's one of the discussions
Yeah.
that's actually taking place now. I'm a part of a work group
Yep.
where we're working on figuring out whether it makes sense to limit the amount of mandated reporters there are, or just do away with mandated reporting altogether. And so there's a lot of tension in the group in regards to what we should do, but we're working it out. We're working it out, and yeah.
I'm so glad the conversation turned here. So thank you all. I mean, I think because one of our goals is to kind of talk about all these intersecting issues, you know? So thank you. Thank you so much. We are going to transition to the next part of our morning.